clinics or the healthcare organizations are making about $70 to $100 per patient per month. It's a reoccurring revenue stream that will literally offset their payroll and sometimes even their rent or office expense.
Kyle and Doug, thank you so much for hopping on today's podcast. For the listeners, we have Kyle Christopher, founder, CEO of SmartCare360, and Doug Bain, advisory board member for SmartCare360, joining us today. To get things started, Kyle, throughout your career, you've led tech-only, hybrid, and service-first models and have really built SmartCare360 from the ground up. And Doug, you're now helping scale the platform for the SmartCare360 platform. What drew each of you to this space, and how did your early experiences shape what you guys are doing now at SmartCare360?
Yeah, appreciate you having us, Bert. Thank you for reaching out and giving us the opportunity to join your podcast. What drew me into this space was a personal experience, I guess. My grandfather actually passed away from a preventable chronic episode that eventually turned into a hospital error, a bad blood transfusion. And so in the eighth or ninth grade, I kind of went through that, and he was really kind of my idol. He was a serial entrepreneur, had all kinds of different businesses. And so that's what inspired me to want to be in innovation in healthcare. And so I was the first one out of my family to go to college. I didn't know what I wanted to do, but I started pre-med, doing all of the sciences and everything you need to do to get into medical school. While in college, worked for a radiological facility in their business office, learning billing and revenue cycle management, and stumbled across ultrasound. And I ended up getting a degree in vascular, general obstetrical, and cardiac sonography, and built a mobile ultrasound company to serve rural areas. Fast forward, we got hit by the Obamacare, the reimbursement rate cuts. I pivoted, got into diagnostics, and worked with a triple board John Hopkins trained PhD in molecular genetics, pathology, and immunology. And we got into hereditary cancer and preventive diabetes screening. Fast forward, about 2015, I worked on the founding team of a company called VitalTech that was one of the first remote patient monitoring companies. From there, that company sold, and I had a non-compete. And we really did a ton of R&D and followed a lot of legislation, new care models, payment models, all the IoT and cellular technology developments, and have pulled together one of the most comprehensive platforms on the market, which is SmartCare360. So that's kind of a quick background of my stint in the space.
Yeah, very impressive. Doug, do you want to say a couple words on what drew you to this space?
Sure. I kind of come back from the other side. So I grew up in a healthcare family. So my dad was a doctor, primary care doctor, and I got to see up front as the practice of medicine changed. And it didn't change what my dad was doing with patients. It's everything that changed around him. And I saw his quality of life as a provider of healthcare go down. And it's a real struggle if you have to spend most of your time doing bureaucratic tasks and spending time in the medical records and not spending time with patients. And since that time, it's only gotten worse. We're facing, I think, a crisis for physicians out there. So 35% are considering leaving the practices altogether. We're expected to run a deficit about 86,000 providers, and most of it is 62% will say it's because the overwhelming bureaucratic tasks. So they spend about half their time with patients that they spend in the electronic medical record just trying to make it work. So, what drew me into this after years of working in kind of large scale solutions from the PBM side, the payer side, and big companies just don't innovate as well as small companies. What I saw, what Kyle is doing here is one of the best thought out platforms ever to sort of give some life back to the private practitioner.
Yeah, well said. I mean, there's a lot of these independent private practices in the country, over 350,000, right? So if 35% of them are considering leaving, that's a big number. That's over 100K, 120, 130K. So
yeah, we could be in a really bad position in just a few years as a country.
Yeah. And these are practices that are needed, right? Because I think as patients, a lot of them think about what is their nearby health system? What's the ER I can go to when something happens, right? And there's still a lot of private practices out there that treat patients that should be that entry point for them, but they end up going to the larger nearby health system, and that drives up costs for the system, drives up costs for the whole industry. So yeah, let's dig into a little bit of that. Kyle, how do you guys define at SmartCare360 digital health and virtual care delivery? And in your eyes, How has that like evolved in this last decade, coming out of COVID, especially, and nowadays?
Well, digital health and virtual care delivery, I mean, we started out just as a software. We would go into clinics and just provide our software and kind of like a playbook and kind of hand them the keys and say, here's what you need to do. Here's how, we would help train their staff. And it wasn't sustainable. I mean, with clinics, they have high turnover. People don't show up to work, so it was more challenging there. We then created more of a SaaS and a service model, more of a tech enabled service. And that really was more sustainable. It allowed us to enroll more patients and deliver more care without having to rely on the clinic's staff and just, operational barriers that we were running into. When I look at digital health, you have to take into consideration one, just integration, interoperability, and really being able to leverage the EMR data into these new care models and payment models and care delivery programs. And so we've really, created a platform that aligns with the gaps that are in EMRs. It aligns with the integration needs that you need to deliver a continuity of care. And then it includes the care teams and the staff needed to enroll and actually meet the reimbursement guidelines. It's a multifaceted type of model that you need to have all the pieces to the puzzle, or it's going to be fragmented and very hard to scale and make sustainable.
Yeah. And you, Kyle, have like a lot of experience like implementing and supporting different like virtual care programs, right? Are you saying like this hybrid model of SaaS and service, you guys have found to be more sustainable than other options in the market that might be like just tech only or just service only? You're saying that this blend of SaaS and service has really proven to be more sustainable for the programs you have interacted and supported?
Yeah, I mean, I feel like we've seen just about every scenario of ways that you can contract and deliver this service, from just providing the software and training staff and then, delivering the care, enrolling the patients, providing the billing, and the vendor just provides a billing report. The problem that we ran into when doing that ourselves was it's either an accounting like nightmare because you can't reconcile the claims with what's our service versus what's the clinic service. The deposits get lumped together. The other, issue is that the clinics, they're providing this service, they're delivering the care, and the vendor is then giving them a billing report at the end of the month that they have to go manually enter and charge all these claims. But then in a year or two, if they get audited, 3 times we saw that the clinic was not able to pass the audit. The vendor, disappeared on them, and then they get stuck with getting clawbacks and losing revenue that they had already, spent. I think set ourselves apart is we've now got a medical director that was a medical director for the U.S. Army. He took Oscar Health public, but what we've done is gotten in network with all the main insurances. We're now in network with over 50 different insurances, and we integrated our platform to a clearinghouse. And so now we're able to provide an end-to-end solution that includes the patient eligibility, the insurance verification, the enrollment, care delivery, billing, collections, and then the clinic or the healthcare organization receives a clinical oversight fee because they're overseeing the clinical protocols and the care delivery and the triage patients that are not compliant. So it's a seamless, I guess, solution really that removes all the barriers of entry for the provider, and it removes all the operational and financial risk for the healthcare organization or the provider. So that's really, I think, over the years how we've kind of evolved into a model that really removes all the liability for the organization.
Yeah. Yeah. Well said. It's almost like you've seen the different models that work and don't work, and you've now built this like sustainable model that you call, it's very end to end, from pre-visit, like during visit, post visit, ensuring that all of that is as seamless as possible for the practices that you guys work with, especially independent practices.
Not only that, I mean, we've really evolved into more of a practice development or transformation company. Chronic care and remote monitoring and principal care. There's a ton of platforms out there. A lot of them are very fragmented and they're point solutions. They focus on one or two chronic issues or disease states. They have one or two of these different service offerings. And there's really not a whole lot of actual programs to take the patients through. So the patients don't see a whole lot of value in it. And they really just, end up like kind of checking out. With us, we've developed a model that's really personalized around the patient's needs. And we call it the 4 pillars of health. So we look at the patient's vitals, symptoms, and preventative screenings. We look at their medication and medical supply support. We look at physical activity and virtual rehab. And then we have meal planning and nutrition coaching. And so we have optical AI and vision learning and different technology to monitor patients' movements and their form and do musculoskeletal rehab. We have an entire meal planning and nutrition coaching program that's built by registered dietitians with over 50 diet programs where we can take patients through these meal planning and nutrition coaching programs and kind of merge these different things together that's personalized around either their social determinants or the specific disease state that they're dealing with. And with these programs, we've been able to, one, just drive a lot more adoption and compliance from the patients because they actually see the value in it. 2, the outcomes follow. And 3, we're able to generate more revenue because there's more billable encounters as we're delivering this preventative care. And so I think those are, some of the key, points that we've differentiated ourselves. Doug, I don't know if you have anything you want to chime in on.
No, I think this focus on the senior market is key, right? So just globally, look across the U.S., most of healthcare is being consumed by the seniors, right? They need the most help, they need the most care, and among those, the ones that are consuming the most are the chronically ill. So we're in a moment right now where this country is keenly aware of chronic illness as being a substantial problem. It's not only a drag on people's health, it's a drag on the whole economy. So if you can focus on helping these people get the care they need and do it in such a way that alleviates the burden from the healthcare practices, they can focus on those core critical things. The truth about chronic illness is there's some very complex, difficult things that need to be done to treat people with chronic illness. And there's a lot of very simple things. And what we're focused on is these simple things that can happen in the comfort of the person's home in between the office visits for the doctor. So when they return back to the doctor's office, the doctor has all the statistics about how they've been doing on their healthcare measures. They know that they've been getting more exercise. They know that they've been eating better, and they can see their improvement, their performance as they go along. Now, if we can do that at scale, which is the intention of CMS and other people providing care to seniors, doing this at scale is going to have a big impact just on the total healthcare economy, and frankly, that means on the total economy.
Yeah.
If I can add in real quick, Bert, Daisy Wolf and Vijay Pandey from H16Z, Anderson and Hortz, they wrote an article on, the title was The World's Biggest Company. And what they really summarized was it's all about a patient marketplace that's vertically integrated, but that has a horizontal offering. Right. And so, I came across this probably 6 months ago. It was written 2 years ago, but it was really kind of a validation for me of our overall thesis that we're kind of going in the right direction. It really describes what we're doing actively. It's all about solving the point solution problem. These larger groups, even a doctor group, like they don't want 4 or 5 different vendors to solve this digital health virtual care problem.
Right.
They want one vendor, one solution if possible, right? And it also ties in with EMR integration. Like you have to be able to integrate with the EMRs at some level. You have to align the workflows with their workflows, and you have to have the documentation aligned with the provider's needs so that there's a continuity of care, or else the providers aren't going to be as they're not going to opt in as much, and they're not going to adopt it as much. The other thing is IoT integrations, all these different devices, and you have to be able to integrate multiple different devices because you will run into fulfillment and logistical issues. That happened to us. And now we integrate with over 250 FDA approved devices, including Apple, Fitbit, and Garmin. So we won't run into that problem anymore. And then the other thing is that kind of ties into the point solutions is it has to be disease and social determinants of health specific. So what we did is we basically took some analytics and risk stratification tools. We took all the different social determinants of health questionnaires from a general health risk assessment, activities of daily living, psychosocial, PHQ-9, and social determinants of health. So when we enroll a patient, we take them through a series of questions over the phone, or they can complete a form. And through our algorithms and logic, it flags any social determinants of health. It gives the patient a health index score from 0 to 25. And then it puts, based on the diagnosis code, it enrolls them into a care plan that meets reimbursement guidelines. It's a standard protocol, and that care plan is for the health navigators to have a standardized process to take the patients through. And it ties to problems, goals, and interventions around that chronic issue, around that social determinants of health. And at the end of every month, we put a PDF summary into the EMR so that when the doctor now sees that patient and they haven't been in the clinic in 3, 4, 6 months, however long, they're able to see a snapshot each month of why they were escalated or why they weren't compliant, what their vitals were and what the trends were of their vitals, and a medication reconciliation. And that information for a provider walk into a clinic room is very valuable because you're able to have a lot more effective visit, and they're not having to sift through notes for 10, 20 minutes before they walk in to the clinic to understand how that patient is doing or what's going on with them. And I think that's really how we're able to help the providers deliver better care and remove a lot of this administrative, tedious work that they're having to do or someone's having to do, and they're not clocking any of that time that it's taking to prepare for those charts or those patients. And I think that really covers, what digital health is and what virtual care delivery consists of with us.
Yeah, that's well said. And I'm sure your background too, Kyle, has helped informed a lot of this. You've worked in these practices, with different, you mentioned sonography earlier, mammography, you've seen this sort of care plans and reimbursement incentives that go into this. And now you've really been able to, with SmartCare 360, it sounds like build a more cohesive, comprehensive solution. That's not just technology or point solution. It's a SaaS and a service, right? Because I'm sure with these independent practices, they also need to have a lot of hands-on support with understanding those reports. How do I use it with my EHR? I know I use these devices. These are 5, 7 devices I've used. How do I even integrate these things, or get the data I need out of it to then create a care plan. And then when we do that, bill for it, and bill claim, right? So,
well, what I tell, CFOs or administrators, or even doctors that are, in a small clinic is the insurance companies are like the IRS. I use this analogy all the time. They're like the IRS. They're like, what do you mean? I'm like, well, you can have all these deductions and expenses and travel and all this, cost of doing business. But if your CPA doesn't document and report that stuff to the IRS, you're not going to get the tax breaks. In healthcare, you can provide all this service and spend all this time, use all these supplies, but if you're not billing the codes, the insurance companies are not going to reimburse you. And so what we've done is basically reverse engineered the reimbursement guidelines. We reverse engineered all the CPT code reimbursements, integrated those into care plans by disease. All the billing reports have a digital audit trail and footprint. And we even have phone technology that can integrate into the EMR so that when the doctor is talking to the patients or the doctor's in the charts, we're able to track that billable time because the reimbursement guidelines are built around 3 main factors. It's either time, it's a number of vital or medication adherence or remote therapeutic monitoring instances per month, or it's the completion of a physiological health symptom or risk assessment. So we've architected our technology to align with those reimbursement reporting requirements and building these care plans by subspecialty, by disease. We're now at a point where we have contracts in every subspecialty: primary care, endocrinology, cardiology, pain, gastroenterology, neurology, nephrology, and rheumatology, and psychiatry. So we've, I think, really also, created a very, very strong support network for the clinics. I mean, down to the basics. I tell a doctor, what happens when a patient needs something? What do? They pick up the phone and they call your office. What happens? Someone answers the phone, and it's usually a front desk or an MA person, and they run around and they do all the stuff that the patient asked or needs. And it's usually 5 main things. I need an appointment. I need a prescription refill. I need a prior auth or a referral, or I need my lab or imaging results.
Yep.
And someone in that clinic is running around doing that stuff, but they're not documenting the time. And that's patient support and care coordination, which falls under principal care and chronic care. And so what we tell clinics is think of having 2 extra medical assistants or an extra front desk person to help offset all of this care coordination and patient support for every patient that is 65 and up that has one or more chronic issue. And that's kind of how we frame it up for the the clients to look at us as a true partner. I mean, we're literally investing about $100,000 for every 500 patients into a clinic that we have no ownership in. So we're really betting on our service and care delivery models to recoup our investment and make sure that the clinic is still getting a fair margin as their clinical oversight fee. And, one of the biggest problems in healthcare that I've seen is physician burnout. Like, I have a lot of doctors that are friends. I know a lot of elderly providers that they're already in their, above 65, 70, and they're still practicing like 3, 4 days a week because they don't have a retirement. And I don't care who you are, but if you can put 10, 20, $30,000 in someone's pocket that they didn't have the month before or the quarter before, and that's coming in reoccurring consistently, that will
Yep.
help physician burnout. I've seen it
100%.
firsthand. And so there's tons of doctors out there that have, they're not, it's not easy to be a doctor. It's not easy to run a business, much less a practice. And they're working on very small margins. And the government has put this out to incentivize them to adopt these new technologies and these new care programs. They're just making it very hard to get the money. And that's where we
Right.
come in to truly partner with them.
Yeah, very fascinating. I mean, it's clear you guys don't just help them establish these workflows that they need and there's already reimbursement mechanisms around. You guys actually help them achieve that reimbursement at the end of the day. I think that's what really I'm hearing is what you guys are doing at SmartCare 360 different. And Kyle, question on the technology itself, right? Because a big part of this with physicians is not just like the running a business that's tough and improving margins, but it's also like trusting technology, right? How do you guys like validate your technology at SmartCare 360 and work around like common EHR limitations like data reporting? Can you say a few words on that?
Yeah. Well, the first, point to make, I think, is use cases, right? Like, if you don't have patients, if you don't have clinics, if you don't have certain disease states or certain problems that you're trying to solve, and you haven't went and built the technology to solve that, then it's going to be, a lot more difficult to do it at scale, and your reporting is going to be off. So we started with data. Like, we went and over 25 different community health assessments. These are what counties have to pay a third party consulting firm to write up. And it basically breaks down what they spent all their state and federal dollars on, what problems they addressed from 1 to 10 as, the level, and what they're going to spend next year's funds on. So we pulled a bunch of these and really understand what are the problems by rural, urban, and metro. There's a book called Community Cure written by Dr. James Masco. And it's basically they recruited a group of influencer status doctors that are leveraging digital health tools throughout the country. And they interviewed them and got use cases of how they're leveraging digital health tools within their practice. I read that book probably 6 times, documented tons of different use cases that we could bake into our technology. I then moved to Houston from Austin, Texas, and literally interviewed over 2,500 clinics within 24 months. Walked in clinics and interviewed front desk, office managers, administrators, MAs, and doctors, and understand what are the biggest challenges they have to operate and do business and deliver care, and their scheduling and all the different things that go into their day, and took all that into consideration. We then studied EMRs, and we said, where are all the gaps into the EMRs that we need to build bridges around or plug holes in? And now we're like a bolt-on. We bolt on to every EHR through HL7 Fire. If there's APIs or we need to do major integration work, then we're willing to make that investment. But that's, really kind of the R&D phase. Then it went down to delivering the service. And we went from just being a software company to literally being a full-fledged clinic that's licensed to practice medicine in 17 states. So we've kind of been across the whole gamut of delivering the service. I think with Vital Tech, they delivered or enrolled over 400,000 patients, and there was no real AI back then to leverage, what we're doing now. So we've seen and learned a lot. I think it's really at a point now where we're at a point to scale what we've built, and that's really why we're here. We need to let people know that we're here to serve them and their patients, and
Yep.
we're here to partner with independent practices to get them in a better position than they were yesterday. And this is a great tool, and it's fully backed by the government. And so they need to start taking advantage of it before it's too late. And, I can't stress the passion that's behind here, not just with me, but with everyone on our team. Like this is built around doctors, it's built around patients. And I think that's one of the biggest problems in this space is there's too much money going to the wrong companies and going to the wrong people. There's tons of private equity money out there. When these codes came out, lots of people started trying to build technology, but they didn't even know what they were building it for. They saw this huge, I call it the dot-com boom of healthcare, but they didn't really build it for the right reasons. And we did it kind of the reverse. We went and got all the data, got all the use cases, and figured out what are all the big problems that everyone else has kind of already solved that we'll solve too, but what are the biggest problems that people haven't addressed with delivering this kind of care models at scale?
It's very telling. I mean, you literally said you went to 2,500 clinics in 24 months to understand what the challenges were, and you really dug into use cases, not just like clinically or with their front desk staff, but also with the technology itself and reimbursement to back it, right? So,
and you can see how Kyle and his team have gone, figured this all out the hard way. Like, tried things, they didn't work as well, but really thinking through that provider experience and what's going to get this out of the way. Because the truth is, right now, these programs are out there where CMS has reduced reimbursement for a lot of Medicare services. They've increased the reimbursement for these because they're trying to get more doctors to adopt it. We're still at something between 4 and 8% of practices are doing this at all. So even though there's been a lot of people trying in that small subset, there's a huge amount of physician practices that look at it, decide it's just too hard to do. They can't add another thing into their daily tasks, and it just doesn't happen.
Yeah.
So I think him thinking through and the team thinking through that provider experience end to end to make it as easy as possible has been critical. And that's why we're at this point of kind of scaling. There's actually almost an outstripping of demand from practices that are hearing about it. But I think it's also important to be aware of that patient experience. So we're all at the age where we have aging parents, right? We have parents that are their needs, healthcare needs are going to get more and more intensive over time. 65 and up, but the stat we just got the update on the other day, Kyle and I were meeting with another entrepreneur, 11,000 people turning 65 a day in this country. So they're all going into Medicare eligibility. They're all going to need a lot more help. So what happens? So somebody 65 and over typically is on at least 4 to 6 medications. Chronically ill, it's more. Now, some of those are 3 times a day. Some of those are 4 times a day. Some of those are once a day. Some are before meals. Some are after meals. I can't keep track of the Z-Pack myself, and that's just 1 pill a day, right? So the support that patients need when they leave the office is huge. And so imagine, you've got, an elderly parent who's at home. They saw the doctor the other day. They've probably forgotten half of what they're supposed to do. And here comes help on the phone virtually from one of the health navigators that work for SmartCare 360. And they help them think through everything they need to do and reminders about the medication. And here's the vitals. And by the way, you now have a device that you don't have to attach to the Bluetooth on your phone. And you don't have to have your Wi-Fi working. It's all connected through cell. It takes care of itself. You don't have to worry about calling and reporting in. We'll take care of all that for you. And they get a regular visit, virtual visit by somebody that is the same person every time. They've gotten to know them. They've gotten to feel comfortable with them. It's not surprising at all that the clinical outcomes for these people who just need better help with their chronic care between office visits is dramatically improving.
Yeah. No, I mean, it speaks volumes to that. I mean, I can clearly see the passion both of you have for this, and it affects, to your point, like not just the providers and their end-to-end experience, but also patients. Like people call it the silver tsunami or the boomer generation retiring. Yeah. There's a lot of this, including my own father. You literally spoke to my father turning 65 and older, like this year, next year. And the 11,000 number sounds surprising at first, but it's like, it makes sense, and more of these practices, if they don't cater to that market and effectively do it, they won't grow as a business at the end of the day, and they won't help their patient population that's aging, right? And is going to develop more, unfortunately, whether you like it or not, chronic conditions will pop up more and more. So, yeah.
I mean, you've heard the saying, time is money. I mean, time really is money in this business as well. Like the time being spent is revenue that they're not capturing. And it's like a grocery store or a retail store. Like they have these POS systems that are to track inventory and things that
Yeah.
are being sold and documented, and like that's really kind of what we're doing. The EMR in our system is almost like a cash register, and we have all these patients that are inventory, right? And how are we going to maintain their health and improve the outcomes and lower costs? And we're doing all these things, but you got to be able to track it and document it and ring it up at the end of the month, or you're not going to get paid for all the work you're doing.
Right.
And I've met with multiple like large enterprise health systems. Actually, I met with New York CEO Israel Rocha. He's now at Kaiser, but I mean, he told me word for word. He's like, Kyle, like, have you validated this technology? And I said, yeah. I mean, we have this many patients. There's already been over 20,000 patients enrolled using the tech. Like, we have paid customers by subspecialty. And he made an analogy that he said, we around here we got what we call $1 million closets. I'm like, he's like, it's closets where a department director or someone was able to sign off on something and the stuff wasn't vetted and validated correctly, and it's just sitting in the closet now waiting for the contract to be up because we can't use it. And so, there's it's important, I think, if people are going to go down this path, to make sure that you're going with a company that has validated technology that can show you historical, proof, and has references. And two, like, make sure that you're contracting and not getting stuck in some agreements that is going to, end up bad business wise, or unit economics wise, financially for the healthcare organization. And we've really created a model that puts us on the hook, and it removes pretty
Yeah.
much all the barriers to entry, operationally and financially, for them to capture these reimbursements that they're not.
Yeah, and I want to double down on that and ask you, because earlier you said you sometimes invest over or often invest over 100K into like patient practices and their patient populations. And it's basically like you're saying, this zero barrier to entry model, right? Can you tell us a little bit, maybe Kyle, Doug, and how you manage like financial operational risk for these practices and with this model? Yeah.
Sure. I mean, in talking to over 2,000 doctors, I learned a lot. I mean, this is a very complex business, complex sale. You're getting full access to an EMR. You're, getting all the data sets. So it was a steep hill to climb, I guess, to figure it all out. But what we've done is we've really created a model that helps them feel comfortable referring us their patients and providing the service on their behalf. And how we do that is first by predefining specific objectives and deliverables and things that we're going to execute on their behalf, that ties to predefined measurement standards and what a success and what a failure is. We also predefine our implementation and configuration steps, so that, because they're signing off on this stuff, and it's all kind of standardized now in templates based by specialty and chronic issue. But it really helps them visualize what we're actually doing with their patients in between their office visits, and it makes them feel more comfortable to sign off and refer their patients to us to provide these services. We've created a model where it's zero out-of-pocket costs. There's no long-term contract that they're stuck on. They can get out with a written notice. It doesn't require any staff or any space in their clinic, and zero out-of-pocket costs. And we do this all on a success fee. So we're basically taking all financial risk on the program. And out of every dollar that comes in, the clinic gets an oversight fee of about 30 to 40 cents on the dollar. It starts out at 30, and it's a tiered structure. At 250 patients, it goes up a certain percentage or dollar amount, and that's their clinical oversight fee that they're getting paid to oversee the clinical details of the program, and make sure that any of the patients that aren't compliant, that are escalated up through their EMR, that they tell us what to do within a certain period of time. And so that's basically how we've created that model. We also basically cover everything from identifying the patients, eligibility, insurance verification and authorization. We do the enrollment. We health wish stratification of the patient, and give the patient a health index score. And then all of the care delivery, the enrollment, the revenue cycle management, and the billing and collections, and then all of the accounting of it, and making sure that the doctor gets their margin for their patients that they're overseeing. So at the end of the day, the clinics or the healthcare organizations are making about $70 to $100 per patient per month, depending on what the patient consents to, and depending on what care we deliver. But it's an average of about $100, and it's a reoccurring revenue stream that will literally offset their payroll and sometimes even their rent or office expense.
Yeah.
So that's kind of how we've structured it, and we've had some success. It feels good to see the doctors really just seeing the benefits of what we do, because there is a lot of skepticism in the beginning for different reasons, and I think that's one of the main reasons why we removed all the barriers to entry.
Yeah. And then what are some of those success stories that come to mind? Because you mentioned you're in several subspecialties, just about all of them. An example of a doctor or practice that was skeptical at first, and after helping them out with enrollment or adherence or simply reimbursement, billing and reimbursement, that they were happy about. Do any success stories come to mind that you're willing
I think
to?
the success stories are broken into three buckets. One is like, how is it helping operationally? Two, how is it helping the patients clinically? Three, how is it helping the clinic financially? And so looking at those three buckets, I mean, there's one, I mean, we've been into clinics where there was no phone tree. They didn't even have options for their phone, right? And you go start calling every patient in the EMR that's 65 and up, that phone's going to start ringing. And if there's no phone tree, it's going to become a cluster, bottleneck. So we really look at this as from the time that the patient schedules an appointment to the time that they're checked out, and like what is the journey, what happens at each stage of that experience for those patients, and where do we fall in, and how can we be a resource to the clinic. So that's how we kind of go in our implementation, and they can offload whatever they want to us. We will do whatever they want with the patient 65 and up, as long as it falls under patient support, care coordination, and virtual care management, right? So one is how can we offload a lot of these things that the staff is getting stuck with? How can we make the patient experience better, and how can we make the provider and the staff satisfaction better? And I think in all of our accounts, we have references to doing that successfully. The second thing is clinical outcomes, right? We obviously want to prevent people from going to the ER. Like that's, a given. We also want to maintain vitals and biometric information and physiological symptoms, right, that fall within the chronic issue that we're managing. We want to keep primary care patients from getting referred up to the specialist, if possible, that we can keep as much of that business under that primary care roof as possible. And so we have tons of success in doing that. We did have a gastro group, Texas Gastro Institute. In less than 6 months, we prevented 12 ER admissions. So that, I mean, you go into a managed care contracting or value-based care, and you're, utilizing those incentives. That's a big savings right there that you could eventually potentially get a cut of if you're doing managed care contracting or value-based care. The enrollment piece. I mean, we have we've been to a point where we've been enrolling 25 to 30 patients per day with one part-time, 6 hours a day enrollment specialist. So we can really enroll these accounts a lot quicker because of all the technology and just bridges of tools and things that we've built. Towards a clinic is going to try doing this through their landline phone with someone physically dialing, listening to the phone ring. When we have like power dialers, we can call from the clinic's phone number. We have telephony built into our system, so they just click on the number and it's ringing. And now we're even integrating our AI technology where it's literally doing automated outreach, and you can click to call and it'll automatically link them with someone, and it pretty much automates the entire enrollment. And with that, then it feeds into revenue, right? If we're now capturing a lot of these care coordination and patient support encounters that were coming into the front desk phone, and they're feeding them to us, whether it's through a live transfer or they're messaging us and we're taking over, that's new revenue. That's something that in-office staff could be doing something with the office visits. Shoot, go call patients and get them on the schedule. It's a better use of that front desk person's time, right? And so we really look at now, how are we going to drive revenue? Obviously, us delivering our care is going to generate the clinic, $50, $75 a month per patient recurring revenue. But what are other things that we can do? What are other programs that we can get the patient enrolled into? And what are other administrative burdens that they can offset to us or offload to us for those patients that are 65 and up? So it becomes, like I said, more of a practice transformation. We're not trying to come in and sell a widget or a drug or a device. Like, we're coming in here to help build your business, to deliver better patient care, and to drive new profitable revenue and create new savings opportunities through our offering.
Yeah.
So I think that's kind of summarizes it.
Yeah, no, that's great. I mean, it's just very fascinating to hear the breadth of the impact you guys have in this practice transformation, operationally, clinically, financially, patient experience wise, staff satisfaction. It all plays a role, and it's clear you guys are leading the charge on practice transformation for independent practices. Now, if this, we talked about how well the model works, the technology, the success stories. If this model makes so much sense for independent practices, and there's over like 350,000 of them in the US, like we talked about, why haven't more of them like adopted it yet, in your opinion? And maybe Doug, you can take this one.
Yeah, I think there's, I think the biggest obstacle has been, it hasn't been a clear path for these practices to get up and going, right? So a lot of them would start trying to do it themselves in terms of, we can deliver virtual care, we can send our patients home with devices, try to do the remote patient monitoring. The electronic health records aren't really set up, designed to facilitate that type of care. And so they got frustrated, they stopped. Or it could be that, another vendor walked in the door and said, we're going to give you all the devices and we're going to help you connect it to your system. So here's all the devices, use our devices to go out there, without any thought to how do you actually do the collections at the end? How do you do the revenue cycle management to make it all pay off? So I think there's been a lot of starting and stopping by a lot of different practices. And that's really just the practices that feel like they have the wherewithal to try something new. Again, most of them are maxed out on what they're doing with administrative task and burden. So a lot of them aren't even thinking about it yet.
Yep.
So when they do get a chance to hear that there is a process and a system available that can take all of that end to end and take all that burden off and make sure that there is an accountable party out there that can deliver this care in a way that's going to help the patients deliver the oversight fees back to the practice and improve their margins, and do it without disrupting their whole workflow, without causing them to stop and pause and invest a lot of money making happen, then the light comes on and then they can do it. So it's really, at this moment, now that's, again, very well wired in, it's making sure the word gets out there to practice that there is a better way to do it. And we're kind of just at the beginning of that happening.
That's well said. I mean, like, it's two things stood out from that. One, there's not a clear path for these practices. The path has always been, hey, try this point solution, try this piece of virtual care technology, or try these devices for remote patient monitoring, whatever it be, and what they actually need is a comprehensive like path to like pull all this together, from the point of delivering the service to all the way at the end, like you said, revenue cycle and collections, or collections and, both of those things, RCM, let's call it, right? So all of that plays a role. And
for a lot of these practices too, it's like they've got a fair number of patients that haven't even been to the doctor in a while for whatever reason, and the doctor doesn't know what's going on with that patient, right? Our system can actually go out there and help reactivate these patients that haven't been to the doctor in a while. So if a patient hasn't been to the doctor within a year, they're not eligible for these programs at all. So we can do that initial outreach, get them in, have a virtual care visit, get them activated, and all of a sudden, the doctor's practice is not only benefiting from all this remote care that's going on their behalf, but those patients are actually coming into the practice more often. And that's just fundamentally good for the patient and fundamentally good for the practice from both a revenue and a clinical perspective.
Yeah, definitely. Yeah,
to touch on that a little bit, I had 3 meetings this week. One of them is a 17 location FQHC, and every person that I meet with, like 90% of the time, is either doing this or they've done it in the past. There's very few that haven't tried it out. And I think what's preventing most people from doing it is the cost. Like, you need to have people that are $20 to $25 hour employees per head. And if you have 1,000 patients, right, and you're spending either 20 or 40 minute blocks per month, 1,000 times 40 minutes, that's 40,000 minutes. If you divide that by 60, that's 666 hours that someone is going to have to spend to do this. You multiply that times $25, that's $16,000 in payroll.
Yep.
Right? So who's going to pay that bill? And you're going to have to deliver all this service for 45, 60 days before you even make a dollar. So that's one of the main reasons. The second thing is it's a complex business. Like if you're trying to do this through the EMR, you're going to fail. Like you're going to be losing revenue. You're going to be barely being able to pass audits, if that. And I've seen it firsthand. This FQHC, they're doing this through their EMR. They're switching everything over to us. Actually, they're not. There's chronic care is being done through a third party, but they've been doing it for 4 years. They have a couple hundred patients, but they got over 7,000 patients that qualify. So they got a couple hundred patients on. They've been doing it. It's costing them money. They're having to pay a senior person to manage the program, but they can't be generating enough revenue to even break even.
Wow.
Right. And so it's then running into the data sets. Like the EMRs are very difficult to pull all the different data pieces that you need and then have your data set. And then what do you do with all that data? Right. And so limited data, limited reporting. There's not digital audit trails and footprints in the EMRs for this stuff. And they don't have phone technology built into them. So now someone's having to dial a phone number every time. And the user experience for messaging and patient engagement and stuff, it's just not there in the EMRs. They also don't have all the pre-built reports and things that make it very easy for us. Within 3 to 5 days, we can get a brand new employee, put them through our training, and within 3 to 5 days, they're delivering care. Try doing that in an EMR. It's going to take 3 to 5 days just to learn the EMR, and so we really made it simple. And then now that we're in network with all these insurances, we basically link the provider to our group, multi-specialty group, and that allows us to provide all of the revenue cycle management, billing, collections, and it totally removes the financial and operational risk and the burden of having to worry about in 2 or 3 years if this vendor leaves and is no longer with us. How am I going to pass that audit if they come in and knock on my door and say, show me why you collected $600,000 last year, and you can't pass that audit? That $600,000 is going to be gone. Right. So we've really been able to, I think, make it easy, make it seamless, and the goal is to make it really a no-brainer.
Yeah,
and
it's been a very intentional build out from everything I've heard, from a technology and a service perspective, right? You guys are really understanding what are the blockers for these practices, right? And different point solutions that have been tried before, and you guys are helping them establish that end-to-end like workflow. Essentially, you are their practice transformation partners, from what I'm hearing. So, and on that point, for those like listening in the audience who may want to partner, invest, or simply explore your SmartCare 360 platform, what's the best way to connect with you two online and with the rest of the team?
Sure. I mean, our website has a contact form that you can coordinate time. It's smartcare360.health. That's the the website that really explains kind of the capabilities of our platform and what's our customer patient facing brand. My LinkedIn is Kyle Christopher. You can message me there. But website, email is kchristopher@smartcare360.health. But those are 3 ways that you can get in touch with me.
Yeah,
yep.
Well said. Doug, how about yourself?
I'm the same ways, and I'm Doug Bain on LinkedIn. Pretty easy to find.
Okay, right on. Guys, it's been a pleasure speaking to you too. I'm really excited to keep tabs on your guys' journey at SmartCare 360. I think you guys are beyond just building the technology, the platform, really delivering real like transformation for these practices that need help. And it's clear that you two have put a lot of intentional work and passion into this to build something that's meaningful and is not another just point solution or technology in the market. So I appreciate the work you guys are doing, and I'm sure others will too as you continue to grow. Yeah, thanks for being a great guest today and for all the great insights. Appreciate you both.
Yeah, thanks for having us, Bert, and appreciate what you're doing as well.
Yeah. Thanks, guys.
Really enjoyed it.